This is Dr. Ted O'Connell with the Med Prep to Go Step 2 Qbank podcast. Today we'll be reviewing 3 ENT questions. Just a reminder that you can find these and many more at medprep2go.com. If you'd like to get involved with this project, please contact me at ted.medprep2go@gmail.com. And if you like what we're doing, please consider giving us a review and letting your friends know about this platform as well. All right, let's get started with the first question. A 40-year-old woman presents to the clinic for intermittent pain in her jaw. She's been having intermittent discomfort on the left side of her face for the last 1 to 2 months, with frequent episodes of having a dry mouth. She has also noticed episodic swelling of her left lower jaw, as well as discomfort when opening her mouth at times. She has noted a painful area under her tongue, especially when she is hungry and when she eats. Her medical history includes hypertension, for which she takes hydrochlorothiazide. Her social history is significant for an 8-pack-year smoking history and drinking caffeine consistently throughout the day, usually in the form of coffee and diet sodas. Vital signs are normal, and physical examination is within normal limits, including no cervical lymphadenopathy. Which of the following is the most likely diagnosis? A. Cluster headache. B. Retropharyngeal abscess. C. Sialolithiasis. D. Sinusitis. Or E. Trigeminal neuralgia. The correct answer is C. Sialolithiasis. The patient most likely has sialolithiasis, which is defined as a calculus in the salivary glands or duct. Signs and symptoms are variable and depend largely upon whether the obstruction of the duct is complete or partial and how much resultant pressure is created within the gland. The development of infection in the gland also influences the signs and symptoms. Sialolithiasis can present with a gritty feeling under the tongue or jaw and or pain in those areas. Sometimes, as the stone moves, it can cause the patient to have a twitch in the eye on the affected side. Stones will form in the salivary gland or ducts following the stagnation of saliva. They are typically composed of calcium phosphate and hydroxyapatite, as the saliva is rich in calcium. Common risk factors associated with sialolithiasis are hypovolemia, diuretics, anticholinergic medications, gout, trauma, smoking, caffeine use, and a history of nephrolithiasis. The classic treatment of sialolithiasis is antibiotics and anti-inflammatory agents, hoping for a spontaneous stone expression through the papilla. In cases of submandibular stones located close to Wharton papillae, a marsupialization is performed and the stone is removed. Salivary stones do not usually recur, but if they do, the salivary gland may need to be removed. Answer choice A, cluster headache, is incorrect. Cluster headache presents with bouts of frequent attacks, known as cluster periods, that last from weeks to months, usually followed by long periods of relief or remission. Cluster periods present with sharp, extremely painful headaches, in addition to eye findings such as drooping of the upper eyelid, watery eyes, or runny nose. Answer choice B, retropharyngeal abscess, is incorrect. It is unlikely for the patient to have a retropharyngeal abscess as she has no fever, she has intermittent symptoms, she has no lymphadenopathy, and she's non-toxic appearing. Answer choice D, sinusitis, is incorrect. Sinusitis usually includes chronic headache and pain in the sinuses. Answer choice E, trigeminal neuralgia, is incorrect. Trigeminal neuralgia can range from mild to severe shooting facial pain, triggered by chewing, speaking, or even touching the face. It could also cause facial spasms, but usually does not present as a localized painful area underneath the tongue induced by hunger, which is more indicative of sialolithiasis. The key learning point here: sialolithiasis is a calculus in the salivary glands or duct, which can present with an intermittent discomfort in the jaw, pain with hunger and eating, as well as a gritty sensation under the tongue. Question 2. A 46-year-old woman presents to the emergency department for evaluation of fever, dysphagia, chest pain, and difficulty breathing, which developed over the last 36 hours. 2 days ago, she underwent endoscopic evaluation for medication-resistant gastroesophageal reflux disease. Vital signs are significant for a temperature of 102 degrees Fahrenheit or 38.9 degrees Celsius. Physical examination reveals a midline fluctuance in the posterior oropharynx concerning for abscess. Computed tomography of the neck and chest confirms the presence of abscess and evidence of superior mediastinitis. Which of the following structures of the deep neck is most likely responsible for conveying infection from this patient's abscess to the mediastinum? A, the alar fascia, B, pharyngeal mucosa, C, prevertebral fascia, D, prevertebral space, or E, retropharyngeal space. The correct answer is E, retropharyngeal space. The retropharyngeal space is the anterior-most potential space of the deep neck. It connects directly to the superior mediastinum and is bounded anteriorly by the buccopharyngeal fascia and posteriorly by the alar fascia. Infection in this space can also affect the internal jugular vein and cranial nerves of the medulla. Answer choice A, alar fascia, is incorrect. The alar fascia separates the retropharyngeal space anteriorly from the danger space posteriorly. Although infection can be conveyed through fascia, this patient's infection is more likely to have traveled through the retropharyngeal space as it is closer to the source of infection. Answer choice B, pharyngeal mucosa, is incorrect. This is the layer that was most likely damaged during this patient's recent endoscopy. Although penetration of this layer was necessary for abscess formation, it does not connect directly to the mediastinum. Answer choice C, prevertebral fascia, is incorrect. The prevertebral fascia separates the danger space from the prevertebral space. It is more posterior than the retropharyngeal space and less likely to have transmitted the patient's infection from oropharynx to mediastinum. Answer choice D, prevertebral space, is incorrect. The prevertebral space is the most posterior space of the deep neck and extends to the coccyx. It is bounded anteriorly by the prevertebral fascia and posteriorly by the anterior spinal ligament. The key learning point here: the retropharyngeal space is the most anterior potential space of the deep neck. Infections transmitted through this space may affect the superior mediastinum, internal jugular vein, and cranial nerves of the medulla, that is, cranial nerves 9, 10, 11, and 12. Question 3. A 45-year-old woman presents to the emergency department with a sudden onset of right-sided facial weakness. She reports that the weakness began abruptly this morning and has been progressively worsening. She denies headache, fever, or vomiting. Past medical history is significant for hypertension, for which she takes hydrochlorothiazide. Vital signs are within normal limits. On physical examination, she is unable to close her right eye, raise her right eyebrow, or smile on the right side. There is no weakness in her arms or legs, and her speech is normal. Which of the following is the most likely diagnosis? A, Bell palsy, B, Guillain-Barré syndrome, C, myasthenia gravis, D, stroke, or E, trigeminal neuralgia. The correct answer is A, Bell palsy. Bell palsy is a lower motor neuron process that presents with sudden onset unilateral total facial paralysis. This includes the inability to close the eye, raise the eyebrow, or smile on the affected side. Upper motor neuron lesions, such as those seen in strokes, typically spare the forehead due to bilateral innervation? Answer choice B, Guillain-Barré syndrome, is incorrect. Guillain-Barré syndrome typically presents with ascending muscle weakness and areflexia, not isolated facial paralysis. Answer choice C, myasthenia gravis, is incorrect. Myasthenia gravis usually presents with fluctuating muscle weakness that worsens with activity and improves with rest, often affecting the ocular muscles first. Answer choice D, stroke, is incorrect. A stroke causing facial paralysis would typically spare the forehead due to bilateral innervation of the upper face by the cortico-bulbar tract. Answer choice E, trigeminal neuralgia, is incorrect. Trigeminal neuralgia presents with severe episodic facial pain rather than muscle weakness or paralysis. The key learning point here: Bell palsy is a lower motor neuron process that presents with sudden onset of unilateral total facial paralysis. Upper motor paralysis spares the forehead due to bilateral innervation of the forehead. Okay, so that's it for this episode, but please check out our other episodes as well as our many questions that are available online at medprep2go.com.